I'm Ron Gallagher at Maximum Velocity Physical Therapy, and you're listening to HYPERSPEED Radio. You don't have to live in pain, whether you're running, swimming, playing a team sport, or just everyday fitness. We bridge a gap between medicine and strength and conditioning to help you break through at MVPT. Still love it. Still love that intro. Welcome, everybody, to HYPERSPEED Radio. I'm Ron Gallagher of Maximum Velocity Physical Therapy. This is HYPERSPEED Radio, and today I'm super excited for a guest that probably never thought he would be on a podcast. But as a part of physical therapy education, we have to do clinical rotations. So I've had an intern. He's been here 14 weeks. We're going on of 16 weeks. And it's traditional in physical therapy education to give a presentation. But since I'm a one clinician clinic at the moment, I didn't think there'd be all that much value in doing a presentation just to me when we talk all day. So I was like, you're going to be on the podcast. And he was not stoked, but he's risen to the occasion, and we have a really great topic today. We are going to be discussing pain. HYPERSPEED Radio, welcome Derrick to the show.
Thank you for having me, Ron.
This intern Derrick.
Yes. Never thought I'd be here, and here I am.
Here you are. Look at you behind the microphone. Took a selfie and everything.
For sure. Thanks for having me.
Pretty cool. Are you nervous?
Not at all.
He's super nervous, and mostly because if he doesn't do good on this podcast, he fails this rotation. Just saying.
Well, that's the first I've learned about that.
Not really. He's actually done a really great job. Over the years, I've had many, many interns, and I'm super happy with what he's done in the clinic. And this topic of pain is kind of taught in PT school. We're going to dive into that part of it later, but kind of taught in PT school, but not really. And it's a really, really powerful tool in how we interact and talk to patients, and just about everybody who walks in the door, maybe not 100% of people, but probably 95% of people who walk in the clinic are complaining of pain.
For sure.
And let's jump right in. Derrick, why don't you tell me, what is pain?
Yeah. So pain is essentially this output that our brain and body create in response to a stimulus.
Brain and body create. That's an interesting definition. Pain is an output our brain and body create in response to the stimulus.
Yeah.
Before we really get into that, what is the anatomy of pain?
Yeah. Travis, can you put a picture of one?
That's DJ Trav, just so you know.
So this is a picture we have of a woman touching a hot pan. And it starts with the stimulus, which in this case is the hot pan. And then from there is a nerve that runs from the tip of that finger to the spine. And we call that a peripheral nerve. And we have peripheral nerves all over our body, a huge network of them, and they all run back to the spine so that they can communicate with the brain. So from there, the peripheral nerve communicates with the spinal cord, and then from there, it runs up to the brain, and then the brain processes what's going on, and then it sends that pain signal, it interprets it, and then it sends out a motion signal to say, okay, finger, move away from the hot pan. And the types of messages that get sent, they are also called nerve fibers, and they come in two flavors. So you have your A deltas, which they send the initial sharp pain, And then you have the C fibers, which are kind of that dull, aching pain that follows even after you've removed your hand from that pan.
Yeah. I just want to back up real quick. I should have mentioned before we got going, this discussion can get a little technical, but we are going to do our best to give real world examples and make this applicable to the audience. And I think a lot of people are going to learn a lot of things about pain. So when you say A delta or C fibers, what are we actually talking about there?
We're talking about nerve fibers that they get sent, and they're just different types of messages they get sent. So with your A deltas, they're just faster moving than the C fibers, so they send that message to the brain very quickly. I mean, we're talking less than a millisecond, so that that brain can tell your finger to back away from that pan as soon as possible. And then that C fiber comes a little bit later. I mean, we're talking maybe a second later, and then it just says, oh, that pain's still there, just keep it away for now, and then everything resolves.
Got it. So the speed of those fibers is going to be an important part of a later discussion. So we're going to come back to A delta and C fibers. You mentioned, so this essentially it's a loop, right?
Right.
It's a loop. It's a loop from, in this case, from your fingers along a peripheral nerve, interacts with the spinal cord, and then goes up to the brain for processing, and then the brain decides what to do with that stimulus. Are all peripheral nerves the same?
No, not at all. In this network of peripheral nerves, they'll have, different lengths, different locations, and different jobs altogether.
What are potentially different jobs? Like, are we talking about different types of pain?
We are. We are talking about, so we've talked about this a lot in the clinic with inflammatory pain versus stretch pain.
Right. If you've been a patient in the clinic, and if you bring a stiffness problem to the clinic, if the stiffness is what's generating your pain, you've definitely learned the difference between inflammatory pain and stretch pain. Why don't you dive into that a little bit and tell us what's the difference between inflammatory pain and stretch pain?
Yeah. So first, I want to say that I think pain is something that is not taught at all, and that we're just taught, oh, pain is pain. But we don't ever know.
What do you mean not taught?
It's not really taught to the normal person to say, okay, this is what I'm feeling, and this is okay. We're just taught if it hurts, just back off. And this is where that differentiation lies, is that with inflammatory pain, it's a pain that comes on and it stays on when we perform certain movements, when we do certain things. And even once we kind of stop doing that movement, that pain still remains. And we don't like that. But stretch pain, on the other hand, is something that we're totally okay with. It's that pain that comes on when we perform that movement, when we go in that range. But then once we back off, that pain goes away. And that's something that we need to normalize a little bit more in physical therapy so that people know, hey, it's okay to go through this, because once you back off, if that pain goes away, we're getting stronger. We're getting better in that range.
Totally. And referred pain and radicular pain are other types of pain, are other sort of subsets of inflammatory pain. Our body's really amazing at mapping out sensation, but not terribly great at processing that information. And sometimes we can get referred pain or radicular pain. What's that?
Absolutely. So with radicular pain, this is something that more people will have experienced, and it's, for example, like shooting pain down the leg when we have back pain, right? So essentially, it's a type of neuropathic pain. So it's following that nerve, and it's just following the pathway, and then it shows up elsewhere. So for example, with the back, then you'll have that pain that starts from the back, but it's coming down that leg, and it might show up in the leg instead. And then as we start to what we call centralize it, and we start to make it better, then it starts to move back towards the back. But it follows a very strict pathway.
Yeah.
Whereas with referred pain, then it is a different mechanism altogether. It's like jumbled signals. As the pain, crosses and it's trying to move, then it just gets mixed up with other locations. So an example of this would be like a heart attack, where, in PT school, we're taught, hey, if you have a heart attack, you should be looking out for neck pain, jaw pain, back pain. Like all of those things don't have necessarily a connection to the heart itself. It just got mixed up somewhere along the way and it shows up as those things.
Right. One thing I say in the clinic all the time is sometimes your brain can't determine if it's the highway itself or the information traveling on the highway, and the signal gets mixed up. What is allodynia or hyperalgesia?
So those two concepts are rooted with chronic pain. People who come in and they've been hurting for years and years and years. And they are essentially both types of exaggerated pain. So with allodynia, then we're talking about a normal stimulus. If I just brush your arm, if I just gave you a little tap, those things would come off as ouch, ouch, ouch. That's a lot of pain when it shouldn't be. Hyperalgesia, on the other hand, it's a painful stimulus. So if I gave you a pinch, but you told me, oh my God, that's a 10 out of 10 pain, and that's not normal. And those things are essentially what we need to correct.
Gotcha. What what are some factors that influence pain?
Okay, so pain is an output, and you and I could take the same stimulus. So let's say that someone took a hammer and hit us both with the same level of force right on our hand, and you and I would still say a different level of pain. I'd say it's like a 5 out of 10. You'd say it's like a 3 out of 10, and that difference,
tough.
Yeah,
Tougher.
You're my CI, so I have to give that to you. And so the reason for this is what we were taught in PT school as the neuromatrix. And
This is a
really
great
cool.
concept.
Yeah.
I actually never heard about this until you started talking about it. It's very cool.
Yeah. So imagine your grandmother, right? Everyone has their own memories, their own sensations, everything associated with your grandmother. And that's going to be different than, let's say, your brother's version of your grandmother, your dad's version, your mom's version. Well, that's the same thing with pain. We call that a neurosignature. And all these neurosignatures that relate to different painful experiences make up the neuromatrix. And it's the reason why we have different pain levels despite having the same stimulus. And there are so many things that go into one person's neuromatrix, right? You have experiences, you have culture, you have just the sensory input itself, how it felt. And then you even have all these mental aspects like attention, expectations, even anxiety and depression. All of that plays into what you are going to feel if someone pinches you, what you're going to feel with all these different pathologies.
Right. I mean, you probably heard me say now 100 times, what you think about what you feel is just as important as what you feel.
Definitely.
And that speaks to that neuromatrix, your neurosignature, which I love. In fact, we got to use it yesterday.
Yeah.
Which we'll probably get to in a little bit as well. Another way that I describe this in the clinic is, let's say two guys smash their finger in the doorway. The same exact finger, the same exact force of the door. If one person has a soccer game tonight and they smash their finger, they're going to have a completely different emotional experience than somebody who smashes their finger and can't play in their piano recital tonight.
Right.
Maybe there's 5,000 people going to come and see this guy play piano and he smashed his finger in the door. Those two people are going to have two different experiences with pain because of the emotional connection to the pain.
Definitely.
So we, as physical therapists, see that happen so often. It's never the same back, it's never the same neck, it's never the same shoulder because of this neural signature.
Right.
What are some myths that we commonly see and commonly educate people about pain?
Sure. So one of the biggest myths with pain that a lot of people believe is that if I have a greater injury, it's going to mean I have more pain.
So the size of the injury is not necessarily related to the amount of pain.
Exactly.
Yeah.
And
Huge.
very huge. There is no direct link that has been shown in science, in literature, to say that the amount of tissue that is damaged is related to pain. There was this really good study in Japan where they looked at the MRIs of X amount of people. And what they found was that 40% of the people who reported no back pain actually had a bulging disc. And we've talked about this conversation a lot where you can have this torn rotator cuff and still be completely pain-free.
Totally.
You can have knee osteoarthritis, still be fine. So you are not defined by the impairments that you have. They don't necessarily cause pain. Huge.
Yeah, huge.
And then another myth that we have to address is I'm hurting because I'm old.
Oh man, I hate that.
I know.
It drives me up the wall. People in my clinic, and you know this, are not allowed to say that.
Yep.
Do not say that to me. It drives me up the wall. Go ahead. Sorry.
So, do we have degenerative properties when we age? Totally. But does that mean that pain is normal as we age? Not at all.
Not at all, everybody. Not at all. Travis,
You've heard it
did you
here
get that?
first.
I heard it here. It's not. It's not at all. Not tomorrow.
Not at all.
yesterday.
There was a couple studies done where they looked at age changes in the spine compared to the development of arthritis. So, Travis, can you put up the next picture with the graph? Okay. So, the blue line here represents low back pain that was reported by this population. And the green line represents the development of arthritis as we age. If those age-related changes were related to pain, those lines should be one over the other. They should be matching up completely.
Yeah, they should be traveling at least parallel somewhere, huh?
They should, and they don't.
Is it inversely related?
It could be. It definitely could be. And that's the thing, that pain is so subjective. It's so much related to that person's neuromatrix that we can't say that, oh, just because you're aging, that's why everything hurts.
Drives me up the wall. Another thing that drives me up the wall. Showing up to the doctor's office, not even hearing, 2 seconds of what this person has to say, slap up a x-ray on the light box and make a determination of what's causing a person's pain just by the diagnostics.
Right.
That graph also demonstrates why the diagnostics are not all that indicative of what's happening.
Right.
We actually need to evaluate the person, spend a little time, listen, figure out what is generating the symptoms.
Definitely.
So age itself is not an indicator of pain. Well, we evaluate people in pain, like I said, probably 95% of our people. What are some common ways we treat pain?
So historically, we've been taught that if the fire burns you, just avoid the fire, right? If that movement hurts, just don't go into it.
When you say historically, what do you mean by that?
I mean, just through the years of how physical therapy has evolved and how, even in the medical field, how we look at pain. It's all about, oh yeah, take these medications. That makes the pain go away, right?
Right.
And let's just rest. Don't move through the pain. Just avoid those movements.
Avoid the fire.
Exactly. If it hurts to run, don't run. Right. But that doesn't solve the long-term problem. We shouldn't be avoiding the fire. We should be learning how to put it out.
Exactly.
That sounds so much better.
Right.
And if we don't do those movements, for example, then it leads to what we call fear avoidance behavior, right? We avoid those movements. We become scared of it. Then that leads to not using those muscles, so those muscles get smaller.
Right.
As those muscles get smaller, we start to see other injuries because those muscles weren't working and doing their job in the first place.
Right.
And that's where we're at now with the opioid epidemic too, is that, the doctors prescribe medications, here's that quick fix, pain goes away, you must be better, right? But we need to kind of normalize putting it together with physical therapy. Let that pain go away, sure, but now we have to work at resolving that mechanical problem, that long-term issue.
Whoa, That's my favorite word in this whole thing, mechanical. We're getting to that.
Oh, yeah. And then that leads to the next thing is what traditional PT clinics do today.
Yeah, not just traditional PT, but most medicine in general.
Yes.
But I think probably physical therapists have made millions and millions of dollars off this concept.
For sure.
So let's talk a little. Let's get into that.
Okay. So, Travis, you can go ahead and put the next picture up for the projection neuron. Thank you. So, this is what you'll find that many of the treatments in traditional PT clinics are based off of, and it's called the gate control theory. So, stay with me because this gets a little bit technical, but the C fiber that you see at the bottom there is the pain fiber. And then the A beta fiber up top is a non-painful stimulus. So both of these fibers communicate with...
A non-painful stimulus to me means sensory.
Yes.
Yes.
So something like...
Keep that up, please. So the A beta fiber is actually a sensory nerve.
Yes.
Okay, go.
And then both of these are communicating with the inhibitory interneuron, which I'll call here as the gate. So the gate is normally closed. If the gate opens, then it allows that projection neuron there to send a signal to the brain. Whether it's painful or non-painful, it sends a signal. And with the C fiber, let's say you get a painful stimuli, and then it will send a message to the gate, and then the gate opens, and then you get that painful signal going up to the brain, and that's when the brain says, ouch, that hurts. On the other hand, if you get a pain stimulus, let's say you hit your funny bone on the table, and then you go, ooh, that hurts, so I rub my arm really fast. Why do people do that? It's because of that sensory stimulus, that A beta fiber. So when you rub your arm, then it essentially sends a signal to the gate, and it says, hey, you can open, but you can just send this signal instead, which is a non-painful stimulus. It's okay. So it overrides that pain stimulus and says, oh, nothing hurts. It's okay. And that's what we see in traditional PT, is that things that are considered gate control theory would be like ultrasound, a TENS unit, ice and heat. And all these things, they mask that pain signal while you're using it. It feels good, but it doesn't do anything to change all that.
Yeah. So if we recap that picture, the A beta fibers are actually sensory information that travels faster than C fibers. C fibers are carrying pain. So if you bump your elbow and you rub it, the sensory fibers are faster to the inhibitory neuron, and it basically removes the pain information, but it doesn't actually change the place that the pain is coming from.
Right.
It changes your brain's perception of what it's experiencing.
Yes. And so the funny thing is that even in PT school, the things that we learned about those modalities like ultrasound and TENS and all that is that there's little to no evidence to support their use. They feel good in the moment, but if pain is a perception, it's an output, then the time that you leave the clinic, then you're back to square one. You didn't do anything to change how it's going, how that tissue was damaged. You just made it feel better in that moment.
Yeah. I don't think that that's good medicine.
Not at all.
I mean, obviously, maximum velocity is built around the opposite of that.
Right.
Which is what?
Good strength training, good rehabilitation, and teaching the body how to heal itself.
I say every day, don't ask for a lighter load, ask for a stronger back.
Right.
And we treat these problems mechanically, not necessarily chemically. And the chemical fix is closing that gate.
Right. Right. So basically, if gate control theory is what traditional PT clinics do, then we need to change something up. And if pain is perception and it's how we think, then it starts with how we as clinicians talk to our patients. I think the words that we use, the pictures that we show, the models that we demonstrate can really make or break patients, right? We can either say, oh yeah, you have this, herniated disc and it's sticking out. We use all these big words and we sound fancy, but all it does is increase the anxiety in our patients and increase their level of pain, their perception of pain.
Totally.
There's this study, super interesting. You have two groups, a experimental group and a control group. And all of them had microdiscectomies, which means that they removed a part of their disc that is in between their vertebrae and their back.
In their back. Got it.
And the experimental group was given their excised bad disc. They said, hey, look, this is your piece of your disc that we took out. That part that was hurting you, it's right here in this jar. Go ahead, bring it home, put it on your nightstand, whatever.
Yo.
And the control group was shown nothing. Both groups got PT, the rehab, whole thing. And what they found was that the experimental group actually healed way better than the control group because they could see it. They could see that piece of the disc and they truly believed, well, the bad part's out, so there's no other reason why I'm hurting. So I'm going to get better.
Whoa.
Even though both had the same procedure. So it's like seeing is believing. And we see this in countless other studies. There's another one here that they did a meniscectomy, which is removing that piece of the meniscus in the knee. And same thing, they had two groups. They had a surgical group and then a placebo group. And the placebo group sounds kind of sketchy because they made an incision and they didn't do anything, and then they kind of sewed it back up. And that sounds horrible to me. It's like a scar all for nothing. But
that's what they call a sham surgery.
A sham surgery, which sounds horrible. I don't know what the ethics are of that, but I double check that. Maybe you can get a class action lawsuit for that. And what they found was that they were trying to check the efficacy of their actual surgery, but they ended up learning more about the sham surgery because their results were that both were equally effective. People who got the actual surgery, people who didn't even get the surgery but still had the incision,
right?
They believed that they got the surgery,
right?
So they got better, even though mechanically everything was the same.
That's amazing.
So
the brain is amazing.
Yeah, exactly. The brain truly believed, and that's why it's so powerful. That's why, all this pain education is so important.
Yeah.
And it can go the opposite direction too. So everyone's heard of the placebo, but we have the opposite of that, what's called the nocebo. And so let's recap what a placebo is, right? It's believing you got the real thing and then it works. Well, the nocebo is the negative expectation that something comes true and then it does. So let's say, for example, I'm going to give you a flu shot. And I'm going to say, this shot is going to be the worst shot you ever had. It's going to kill you. It's going to hurt you so bad.
Right.
And I give you that shot. Chances are it's going to hurt pretty bad.
Right.
I put that seed in your mind, and now it hurts.
Right.
And that's just the power of words, the power of communication.
Totally.
We can either give people hope or we can also increase their anxiety. So that's why we have to be so careful with how, we have this power as clinicians to say, hey, I went to school for this, I know this, but that means that we have this responsibility to educate our patients so that they don't fear their own body.
Right. Right. Totally.
So how we start is that, treating patients, it starts with education. You've told me time and time again that we are first and foremost educators.
Totally.
And I didn't believe you, but here we are, talking about pain education. And so there was a study done where they took a systematic review about the efficacy of pain education. It covered 13 studies. It looked at 734 subjects. And some of the individual findings that they had, so one study found that at 1 month, just with pain education, the experimental group did significantly better with pain ratings than the control group. So they reported less pain just because they understood their pain. 1 year later, even a year later, their pain was still way better than the control group who never got that pain education. And that totally makes sense because they were able to take control and own what their body was feeling. Another study looked at, the pain threshold, so the time it takes for you until you feel pain. And just with pain education, within one visit, that threshold was lower. And I've seen you do this in the clinic too, where, this patient comes in and have this high level of pain, and you sit there and you'll talk to them for 30 minutes, 45 minutes. And just by that conversation alone, by the end, they report less pain, even though they didn't do anything.
Right.
But that's just how crazy the brain is.
Right. And honestly, giving them pictures and describing some of the things in this very presentation help them understand that what they're feeling is under more control than they believe, and that the end result isn't going to be as catastrophic as they thought.
Right. Definitely.
It's amazing.
It is. And the other finding that they found from this study was that pain education alone was good, but what made it better was pain education when combined with exercise.
Weird.
What do you know? Huh? So that leads to our next treatment of pain, which is exercise.
Yes.
So I like to say this, is that education paves the way for exercise to create the mechanical change required to fully recover.
Woo!
So
Man.
that's a huge statement.
Huge
so
statement.
let's just unpack that a little bit, right?
Okay.
So if pain is the biggest chunk of the pie, then exercise is the last bit. It's the crust that no one wants to eat. But you have to so that you finish your plate. So the proportions of that pie slice are different for everybody because of their own neural matrices.
Right.
So I can't tell you, it's like 75% education, 25% exercise. It's different for everybody.
Right.
But I can tell you one thing is that both of those together will remove your pain.
Right. It's determining which percentage of each the person needs and then filling in that gap.
Right. And so there was a systematic review that looked at exercise-induced analgesia, which just means reduction of pain using exercise. And what they found as a widespread effect was that just by regular physical activity, that you could block pain signals because it was increasing all the natural opioids and serotonin in your body. And they also found that with regular physical activity, that there's a protective effect over chronic pain development. So you could essentially keep yourself being proactive from getting chronic pain, which is huge.
Right.
And then on a local level, what's happening when that finger hits that hot pan, it's basically that regular physical activity helps to increase your anti-inflammatory cytokines, which is just a fancy word for these little components in our body that fight inflammation and reduce pain. And then the last aspect.
Why do you think that is?
So I think that's because essentially the body is, driving all these ingredients in because it's moving, because it's able to kind of flush all that bad out and circulate all the nutrients that are needed to really heal the tissues.
Well, what if regular exercise is a stress? It's a good stress that your body gets practice removing the byproducts of applying stress.
Right.
So when that hot plate comes, your body's already good at removing that. Your muscles are trained to move faster. Your reaction to that stimulus is better because you play tennis or play basketball or whatever. So your body gets practice at removing those chemicals. And what's really interesting is the people who struggle, and we're going to get into the fibromyalgia population and all that later. Those are people who lose their way athletically or actively,
Right.
and they eventually get to be chronic pain-like because they lose their way.
Right.
So I just find that really interesting.
It's like a domino effect.
Totally.
One falls and they all fall.
Totally. And then what you think about, what you feel takes over, and all of a sudden you're in a downward spiral.
Right. And then the last thing that they found with this study was that there was a mental effect for exercise too. We've heard about how exercise is good for mental health, but it's true. There's been countless studies to say, regular physical activity could reduce anxiety and depression, which once again play into that neuromatrix that tells us what we feel about pain. So all these aspects about regular physical activity helps it on all levels to reduce pain, and that's huge. So there was another study that took 12 men and women, and they basically applied pressure pain on their middle finger. And then they took them through a graded progression on a treadmill, and then they took pre and post pain values. And then what they found was that with aerobic exercise, greater than 50% of your VO2 max for greater than 10 minutes could elicit that exercise analgesia. And there's another study, did the same thing with cycling too.
You said 50% of their VO2 max for 10 minutes or more?
Yep.
Got it.
And then they did the same thing with cycling too. And then same exact find. When you're able to exercise, you see exercise reduced, or pain reduced. And then, I like this one because it relates to yours, but this study looked at the relationship of pain and resistance exercise. So exactly what you do at MVPT. And they took 13 men and women, gave them that same pain stimulus, and then they gave them 45 minutes, a 3x10 workout at 75% of their 1 rep max. And what they found was that they were able to increase their pain threshold, so that time that it took for them to say, ow, that hurts, and a decreased pain rating following the exercise. So, if I didn't know any better, I'd say you were basing your practice off of some actual research, Ron. I'm impressed. Thank you, UNLV.
We're just out here winging it, just throwing stuff around just for the fun of it. That's interesting. I didn't think of that, but increased pain threshold, decreased pain rating as a result of barbell.
Exactly.
It's applied stress.
It is applied stress. We're teaching that body to handle stress. This is a good stress. This has a positive effect, but it's stress nonetheless.
Right.
And the body will learn, and then it'll apply that to pain.
Man, that's amazing.
And the other thing that I found interesting about these studies was that they weren't really specific to a particular pathology or injury. They were very general exercises, right? But it's hard to pinpoint that specific exercise because, we have so many facets when it comes to pain.
Right.
We have the neuromatrix.
That neural signature.
Exactly. It's just so many components. So it's really hard to kind of pinpoint why someone's feeling pain and give them a specific exercise for it. But it's exactly what they need.
Right. We actually had this conversation yesterday. And this conversation was super timely because we were coming in here today and the subject is kind of a big deal around this studio.
Yeah.
Gio gets his move back is a podcast or a show on Gio's podcast, Fitness Junkies. That's filmed here, and he was in the clinic yesterday. We had a really great discussion. Can you share with us how the discussion we had yesterday with Gio shows up in this presentation?
So, correct me if I'm wrong on any of these details, but yesterday Gio showed up and he was just talking about how he feels like, when he squats, he feels this pain in his knees, and he wonders if everyone else around him also feels that pain.
Right.
And what we talked about was that, that's all based on his neuromatrix. Everybody that squats feels that same stimulus that he feels when he's lifting.
Right.
But it's how he interprets it differently from everyone else that makes him say, that's pain.
Totally. So a little bit of a recap on Gio. We're going to say about 30 years ago, Gio had 3 knee surgeries, 2 on the right, 1 on the left. And in his active and personal training life, he's essentially ruled out using his legs in the gym. because of the amount of knee pain that he has.
Right.
And over these years, he's developed a opinion that anytime he feels something bad in his knees, it's going to equal big time pain.
Right.
So the majority of Gio's success has been his ability to change what he thinks about what he feels as he develops more range of motion and more strength. He set his a new squat, a 3x5 squat PR yesterday of 155, which is 100 pounds better than the first time he squatted.
Crazy.
So the change in strength has been dramatic. The change in range of motion has gone from limited to normal, and yet he is anxious to come to the clinic.
Right.
Because he knows that I'm going to make him squat, that I'm going to make him go heavier than he would normally push himself to. And he's been getting 3 days worth of anxiety coming to the clinic because of what he thinks about the stretch that he gets on the bottom.
Right.
And I said, Gio, what's your favorite upper body exercise? And if you see Gio, Trav, you can back me up on this. Gio is a specimen.
Gio is amazing. He has a mental fortitude and physical fortitude.
Yeah.
That it takes a lot.
Yeah. He said cable curls are one of the things he goes to. Like, he just really loves how that works his chest.
Right.
And I said, well, you work your chest a little bit more than you're capable of every time so that you can drive an adaptation, right? He was like, yeah. And you get pain and soreness in the moment from that. And you know that for 2 days, your chest is going to be sore, right?
Right.
He's like, absolutely. I said, your knees are no different, but you've attached this negative connotation to what you're feeling. And now it takes you 3 days to get the courage to come in here and face that pain. So we spent the whole visit yesterday reframing everything that he did. We reframed how he warmed up. We reframed what he felt during all of his lead-up exercises to squat. And then when he set a new PR, we put it in the context of what happens when he PRs his chest. Like, what if, this is a lifetime 5-pound PR in bench? Like, that's a huge, huge change for somebody who spent the life in their gym.
For sure.
And, if you walk away from that with a little swag because you PR'd something that you haven't PR'd in forever, and you don't attach the same value to your knees, then yeah, it's going to make you anxious. So we have to change that neural signature, and we have to influence this neural matrix in order to get him to a place where he's comfortable experiencing that pain.
Right. And I think you said it best yesterday that, we're not just building strength. We're not just building range of motion. We're building courage and confidence.
Right.
The way that he thinks.
Right. He's got to believe in these knees in order for him to run.
Put that on a t-shirt.
Trav, he's going to run.
Believe in these knees? I like that. He's going to run. I think you should get him a shirt and then make him run.
Believe in these knees?
Yeah, believe in these knees.
That's the motto.
The first time we meet him at the grass field, he's going to wear a believe in your knees shirt, right?
Believe in these knees with the arrows pointing down.
He's going to run. Incidentally, I don't know if he told you this, but he's had 2 dreams in which he ran. I told him.
That's manifestation right there.
I told him, once you tell me what your goals are, you're going to start to dream about it. You watch. And he said, I hate to tell you this. I don't want to tell you, but I had another dream I ran last night. I was like, yeah, we're going to run, Gio. We're going to run, baby. Okay. Back to this
professional in service.
Yes. Sorry, didn't mean to take it over. What's complex regional pain syndrome?
Okay, this is a lot to unpack.
Yes.
It's been changed names like over the years, right? Chronic pain, fibromyalgia. I think you called it RSD,
RSD.
reflex sympathetic dystrophy.
Yes.
All these fancy words.
Yes, that's the term I was taught.
Oh,
Yeah.
kind of old, huh?
Old school. Same thing though.
Same thing. So what is it? It is essentially pain and or inflammation, even when all the tissues are healed. So physiologically, if you got an X-ray, an MRI, a CT, or you just went to the doctor, they'd say, nothing's wrong with you. You shouldn't be feeling pain.
Right, you're crazy.
Exactly. And, even in school, we're taught that complex regional pain syndrome is this diagnosis that we give when we've exhausted all other diagnoses, right? There's no true special test for it. So we just kind of say, I don't know what else is wrong, so you must have this, which kind of sucks. Like,
Totally.
That's not the way that I want to be diagnosed.
How much hope does that instill?
Zero.
Zero.
That person just thinks, wow, the doctor can't even figure out what's wrong with me, so I have this label now.
So something must be really wrong with me.
Exactly.
Yeah.
And there's nothing that anyone can do.
Has the opposite effect.
It does. It in itself, that word, that name is just a nocebo. It's that negative expectation
Right.
that they're just not going to ever get better.
And if you go to a Facebook page, a fibromyalgia Facebook page, and you listen to these people talk to each other, it is so devastating to hear the negativity and the lack of hope in all of their words. It's dripping with negativity,
Right.
and they can all be helped.
They can. They
crazy.
definitely can. And what's going on in chronic pain is that essentially the pain is supposed to tell us that a threat is coming. That's what pain is as a defense mechanism for humans. And this has malfunctioned in people with chronic pain. So now everything hurts, everything's a threat, so don't do anything. But there's no benefit to that type of pain in a person with chronic pain. Their body is just on overdrive.
Right.
And if pain is an output, it's our perception, then we have to hit the biggest chunk of the pie first, which is
Right.
educating these patients that their pain does not define them.
Right. Which requires time
Requires time,
and honestly emotional energy.
for sure.
And if I'm a doctor, and in the United States, the average time spent in the doctor's office, the average is 4 minutes. These people do not get their education in 4 minutes. It takes time. I mean, I had a lady a few months ago. We literally talked for an hour and a half for her evaluation. That's all we did. I didn't even touch her. The only time I touched her was when I shook her hand. And we spent an hour and a half just talking about pain, talking about why the things that she's done has changed her brain. And she's amazing. She's doing amazing. And all I did was listen, and all I did was educate her and give her some of these tools, and she's doing amazing.
Right. And that's a great segue into the treatment for chronic pain. A huge chunk of it is that pain education. And then once they understand their pain, they own their pain, then they can start doing those exercises to resolve whatever mechanical issue is there, if even any.
Right.
And we know the solution, so now we just have to implement it well so that
Right.
we can help these patients.
Right. And honestly, walk them through that process.
Exactly. We have to invest in them, and they'll know that they can invest in themselves too.
Totally. And once they feel heard and they understand what they're going through, then they'll put in the work.
Right.
So, Derek, what are your 3 main takeaways?
All right. 3 main takeaways for this podcast. First one, pain is a freaking output. Can't say that enough. Our experiences, our memories, even our mental status, they all play a role in what we're feeling. Number 2, the patients should understand their pain so that they can control it, own it, and ultimately get rid of it. It's our job as clinicians to empower our patients and give them the weapons to fight their own battles. We can't fight it for them, but we can give them everything that they need to do so. And our bodies shouldn't feel like this, scary foreign object that we don't have a connection to. We should be able to recognize what we're feeling and why we're feeling it. And that starts with, our responsibility to educate those patients. And then the third is that if education is the biggest player in removing pain, then specific targeted exercise is that last bit. It's that crust that we need to resolve the mechanical side of the whole thing and remove pain altogether. So, don't just take your medications. Don't just use a TENS unit. Don't just ice it. Don't just rest it. Don't just avoid the movement. It will come back sooner or later, maybe even worse if we do that. So you can start with it, but let's move through that pain and get back to life.
Amen. Hear, hear. Amen.
Travis, you better not do anything bad. You better follow all these tips.
Dude, I'm learning so much. I should be taking notes. Or I'll just watch it on
We
YouTube
can
or
share the
Spotify.
notes with you if you like.
Exactly. Thank you.
So my main takeaways are what you think about what you feel is just as important as what you feel. And if you are not getting heard and you don't understand what you're feeling, maximum velocity is the type of place where you can get all of those things done. And we take how we talk to our patients, we take the education that we provide, we take the exercises that we choose very, very seriously. And we are specifically trying to target the type of pain that you feel and give you the proper education to work yourself out of it. There's nothing that I can do to the person to make these symptoms change. We teach them how to get out of their own pain.
Definitely.
Which brings us to a question that I didn't prepare you for.
Great. Looking forward to it.
I always end my podcast with, what music are you listening to?
What music am I listening to?
I ask all my guests that.
I'm listening to a band called The Score right now.
The Score.
Yeah. Super good workout playlist, and they're all about, a positive message that sends out.
Oh, cool.
So it's super motivating. I
Oh, that's
recommend it to
cool.
all patients and all people.
What's your favorite song?
Ooh. There's a song called Can You Hear Me Now?
Can You Hear Me Now by
The Score. Yeah.
Cool. The Spotify year in review came out. Are you familiar with that? You use Spotify?
I don't, but I'm familiar with it.
So one of the coolest things about Spotify is that they are tracking your music all year, and then they give you this year-end basically presentation or video on what you listen to. So I'm one of the top 1% listeners of the Black Keys in the world. That's how much I listen to the Black Keys.
Someone share that with the Black Keys.
Yeah.
Travis, can you at them?
It's done right now. He's actually on Zoom right now. He wants to talk to you.
Oh my God. 2 years in a row. I don't know if anybody else can say that. That's kind of a big deal. 1% listeners of the world.
That's crazy.
So I've been listening to the Black Keys. What's up? All right. So Derrick, you passed this presentation with flying
Yes.
colors. Nice
Yes.
job, my man.
Thank you.
Even I learned about pain, and I would have considered myself an expert on pain. So thank you for that. In the wrap up, we're going to list all the references. It's a couple of slides worth. So if you're a listener and you want to reference any of the things that he spoke about, it'll be tagged on to the end of this podcast. And yeah, great job, Derrick.
Thank you.
That's all for this episode of Hyperspeed Radio. Thank you.